Welcome to Innersight, Health Optimization with Rudy and Shaun.
Hello, Shaun. Yeah, here we are for our fifth podcast. It's good times, good times.
Yes, nice sunny day in Cape Town, 31 degrees.
Beautiful summer's day.
Beautiful.
Okay, we are here for the fifth podcast. So we've had the first four in our first four on the journey. Maybe you can just recap where we are, and then we'll take the fifth one further today.
Yeah, so we're still talking about the first part of our Innersight program, the part of how to get to 80. So we've talked about cardiovascular disease. Last time we talked about metabolic disease. And today we're going to tackle the big cancer subject. I think the word cancer elicits quite an emotional response on many people, partly because the unknown, you don't know if you're going to get cancer, and because we all know of someone that had cancer, and especially someone that has died from cancer, because unfortunately it's not a quick death, and that makes that mental picture just so much like burnt into your memory bank. So the word cancer certainly makes us all wide-eyed.
Yeah, it's one of those diseases that because it's so wide and it's almost all encompassing, and we've all been personally touched. I think I definitely am sitting here because I've been touched quite a few ways. My dad had cancer very early, had a lucky escape, got his cancer on a screen, his colon cancer was resected. And he's had a happy and fruitful life since then. So he's had a good 25 years after that without any problems. Then I had a friend diagnosed at 40 years old with renal CA. Should have been picked up somewhere on a screen test, and it wasn't. And he died 10 months later. And in the last 18 months, both me and my wife has been diagnosed with skin cancer, which, I mean, if we didn't screen, that could have ended very, very nastily. And I think if we go through this, we'll see that the reason why we're screening is there's a risk. And
yes, absolutely. And I think skin cancer, in your case with sunny South Africa, it's one of the top 4 in both boys and girls. So we'll definitely speak about that as well. Yes, the relevance of cancer. So men, 1 in 2 chance of developing cancer in their lifetime. Women, 1 in 3 chance. In South Africa, we will probably, when we refer to statistics, it will be from the 2008 to 2018 statistics, which was published in 2019, the National Cancer Register. So pretty much equal in the diagnosis for boys and girls in South Africa. The girls slightly above 51% towards them and 49% for the males. Men tend to be diagnosed a little bit later in life, and I know it's probably because men seek help maybe a little bit later than the girls. And the top 4 for men, still prostate cancer, lung cancer, colorectal cancer, and then the non-melanoma skin cancers. And for the girls, it will be breast cancer, cervical cancer, also colorectal cancer, and also non-melanoma skin cancer. So that's more or less the situation in South Africa and our statistics.
Yeah, so, I mean, just to bring the numbers back, between me and you, like one of us will get cancer. I mean, that's what the numbers say. 1 in 2 for men and 1 in 3 for women. So it's like, it's big. So our problem is there's no one cancer and there's no one screen. So we'll have to go through today and try and put together a picture for someone out there what to do. Because, I mean, just to go back, if you want to get to 80, you mustn't die young. And not to die young, you got to know the big things that will kill you And we've talked about the 4 horsemen. So we've done the cardiovascular disease. We put there the strokes we talked about. So if you haven't listened to that, go to listen to podcast number 3. Then the metabolic disease, the diabetes and stuff. So now we're going to work through these cancers and get the risk, what the guys need and girls need to do to not get cancer. And if you get cancer and it's early, how to sort it out.
Yeah, I think that's the important point, is if you can catch cancer early, then you've got a chance. I mean, the last 50 years, if you looked at the statistics, it's around about 30 to 40% increase in 5-year survival over the last 40, 50 years. And that's mainly due to better detection. The metastatic disease is still, the prognosis is still not good for metastatic disease. The last 70 odd medicines for cancer treatments that came to market, with the exception of the immune and drugs that you've got a very specific subset of patients that it works very well for. But overall, you don't gain much. We're talking about months in survival. So the main thing is to find it early so that you can do something at that stage.
Yeah, just to bring our listeners back in. So we talk about metastatic disease. For us, that's a term that means the cancer has spread. So let's talk about bowel cancer. Bowel cancer starts as a little growth in the bowel. It then has to grow through the muscle. So then it becomes a stage 2. If it moves to the lymph node, that's a stage 3. So then you can maybe still catch it with an operation. But the moment it moves to your next organ, which here would be the liver, where you pick it up on a scan, that's stage 4. So what we've just said, if it's a stage 4, so if you pick it up, you cut it out, like with my dad, it hasn't moved through the muscle yet. You cut it out, it's gone. None of the cells got away, and none of his subsequent scans has shown that any of the cells got away. He's clear. So that's what we talk about there. But
yeah, unfortunately, I mean, 70% of all cancers that's diagnosed, there's no screening test for that available at the moment. So we've got a couple of screening tests, and I think in the current time setting, we should utilize those. That's what's available going forward, and we'll speak a little bit later about possibilities that will arise, that we will have better screening going forward.
Yeah.
But for now, and we'll talk a little bit about the screening test for the most common cancers in South Africa. We're going to speak a little bit about our prevalence diseases that's prevalent in our country, and what's available and how effective they are in detecting cancer.
Yeah, I think I want to go back to the metastatic disease before we talk about the screening. So once that cell has gone out and you find it as a stage 4, what you've said earlier with the numbers is that most people will not be alive in 5 years. So
yes.
If you catch it by stage 3, you've got a chance. Then 60 to 70% of people will be alive in 5 years and will have probably a fruitful life after. But if it's a stage 4, the survival rate drops significantly, that only 5% will be alive in 5 years, which is like you have to get that cancer very early. So if it's a stage 4, then you're in trouble.
Yes, absolutely. So the game plan here is to find it early. That's what we can do at the moment.
And then we want to talk about, there's no one screening test for cancer yet. So for cancer as a global illness. Okay, so we have to talk about cancer. We talk about the big 5, and that's what we do in Innersight as well. Pick the big 5 in each gender group. And it's a bit like a Swiss cheese. So you have to do many tests to try and form a picture. Let's say a PSA for prostate is not a great test, but it is a test. So, and we're going to now talk about all the cancers that we're going to pick 4 of the big ones, work through them. So we'll do skin first, and then we'll talk about prostate, we'll talk about colon, and then we'll talk about breast, and how we screen. So, I mean, maybe because it's happened to me, the skin cancer. So there's 3 big ones. I mean, we talk about the melanoma, that's the one that really gets away very quickly, and once it's away, it's pretty much a killer. It stays in the skin very short time, and then it's a stage 4. And before the immune therapy, it was pretty much a death sentence. And then we've got the squamous cell, which is for us and the Aussies and the guys that live on the sunny parts of the world. That's the one that you normally go to your dermatologist, and he burns the little skin lesions before they become squamous cells. So, and then you get the basal cell carcinoma, which is, it's still a cancer, but it's not that aggressive if you can catch it early, and it's normally local infiltrating. So it takes a long time before it will become a stage 2, 3, or 4.
Yeah. So the skin cancers is in the top 4 for both the boys and the girls in South Africa. But fortunately, with the skin cancers, it's an easy thing to screen for. Because you can see it, and then you can biopsy to see what type of cancer it is. So it's basically a visit to the dermatologist or your GP that can you refer then on to a dermatologist. But that's going through your whole body, looking at the skin, mapping the lesions, and follow up. So if you've mapped your lesions and there's a change in the lesion over time, then they'll do a biopsy or treat it.
Yeah, and I just want to come back to my own case. I mean, I saw my dermatologist last year about this time, in about end of October, beginning of November, for my normal, because I've got an open roof. He normally burns a little bit of the precancerous lesions from the sun. And he said, just visit me in 6 months again. And on the 6-month visit, he said, let's just check everything again. And he found a melanoma cancer that started in 6 months. So it would have probably still been okay in my yearly follow-up. But what I'm trying to say is you need to work that into your system to go and see your dermatologist, and try and find a dermatologist that does the mapping. So he says, I've mapped this. This is what it looked like last time. This is what it looks like now. We're a little bit concerned. Shall we take out the lesion? So it's an easy test, as you say. And the fact that it's still amongst the top 4 means that we're not screening properly.
Exactly. And as you mentioned, yearly follow-up. That's important. You doing it, we all should be doing it.
Yeah, and I mean, once you're in that, we are now on our phones and all that. The moment you're there, just tell the lady, I'll book for next year, so that you know that it's in there, and just make it a routine, because that is the one that can get away for us in South Africa, with the sun, with the cyclists, with the runners, all those guys that are in the sun. So you need to have a check.
Yeah, and the social check isn't on. I mean, asking your friend, just have a look at the back, that doesn't work. You need to have a decent examination done by a dermatologist or good GP. And
coming back to that point again, Chantal, my wife, asked me on her back. She said, there's something there. I thought it looked okay. And the moment she got to the dermatologist, what is this? And I mean, I see myself as a good doctor, but still, I just don't have that eye that they've got. And it was a basal cell carcinoma.
Yeah. Excellent. Good that you go for your yearly checkups there.
All right. I think let's take one of the big ones. So for me, I think the understanding of prostate cancer has moved quite a bit since we've been doing our research for the Innersight program. So if you asked me 5 years ago to describe prostate cancer and how it works, how to screen, what is the best modalities, I've changed quite a bit. So I think we need to delve a little bit into that.
Yeah, so prostate cancer, that's a difficult one because there's a lot of controversy around screening for prostate cancer. Incidence about 1 in 15 lifetime risk for South African man. We know that you've got an increased risk if your father or a brother, a relative has prostate cancer, especially if in a younger age. And black men also seem to have a higher risk for prostate cancer. Now, years back when they started screening for prostate cancer, they used the PSA blood test. So it's a prostate-specific antigen. it's a blood test that you can do, but it's not specific for cancer. So it can go up with benign prostate hyperplasia, or it can go up if you've got prostatitis and things like that. So it's not specific for prostate cancer, but it does go up with prostate cancer sometimes.
Yeah. So, and it's late though. So let's build the layers again. So we're trying to build the layers for the Swiss cheese that the ball cannot fall on the ground. So the first layer is genetics. If your dad had it, or your dad's father, or your dad's brothers, you need to screen. Very much like breast cancer, there's a major genetic factor. That's our first. And then the second one is PSA.
Yes.
Also,
coming back to the family one, is if your brother had it, then you've got a higher risk than if your father had it. Just an interesting fact there. So then you need to definitely focus on that screening for the prostate cancer. So we're going to the PSA now.
Yeah. So on its own, a PSA is like flipping a coin. No, not even that. It's like a random number generator. So you just don't know. So just to bring what the PSA is. So the PSA, prostate specific antigen, it should be very high. The count should be very high in semen. It should be very low in blood. So if you find it in the blood and the level goes up, then it means there's been a structural change in the prostate.
Yes.
So it could be very late, but it is still one of the layers of a screening test.
Absolutely. But if we look at the test that we screen for cancer, we talk about sensitivity and specificity. So sensitivity, it's basically how good is a test in picking up the cancer. So if we take 100 people that we know have cancer, and we say this test's the sensitivity is 80%, it means that if you're going to do the test on those people, hundreds of them that we know has cancer, you'll pick up 80 cancer cases. So you'll still miss 20 cases. That's a sensitivity of 80%. Now, if we go look at PSA, and if we use different cutoff values, but if we use the 4 cutoff value, it's got a sensitivity of 21%. So, I mean, you're almost 80% that you still miss by doing the PSA at that level. If you lower the level, your threshold, to around about 3 nanograms per milliliter, then the sensitivity goes a little bit up to about 36% or something like that. But then your false positive rate goes up as well. So you need to get that balance. But having a sensitivity of about 21% isn't a good test. So having only that test available led to a lot of things in the screening industry. So a lot of people were diagnosed with prostate cancer, and they had tests done. And these tests, when the PSA is raised, then you end up getting a prostate biopsy at the end of the day. Okay, you go to the specialist, they do it, and there's risks involved in getting that test done. And the literature then showed that you don't necessarily decrease the mortality or the cancer deaths on a population-based level. And therefore, at some point around about 2012, I think the US stated that they're not going to screen for prostate cancer anymore. And some of the other countries followed as well. Australia as well said, no, they're not screening for prostate cancer anymore, because there's some risk involved in doing the screening, because you can get tests that might be unnecessary. And overall population, you don't save that many lives. But I think for someone that's got an increased risk for prostate cancer, like someone who's got a brother that has prostate cancer, you can't look at population-based risk then. Then you need to look at the individual and decide his risk in that. And that's the person that you definitely want to screen. And then you want to go full house on that. So if we don't only use a prostate value, we can use different ways to look at the PSA value to help us a little bit, like a PSA velocity, where we look at the change of the PSA value over time. Because with cancer, it will mainly go up over time. Of something like a prostatitis, it will come down after your infection or things like that. And you can follow that over time. And there's newer tests available that also might increase your screening potential and sensitivity of this, like the 4K test.
Yeah. And it's a bit of a bugbear for both me and you because we don't have the 4K yet in South Africa.
Yes.
Hopefully it'll be coming soon. So if we move on to the PSA is something we do to get a value to try and get to the next year and the next year, so we get the velocity. Obviously, the next thing is a manual prostate exam. So your nearest friendly urologist do your exam, and as we always say to our clients, get to a urologist your age, try and get to someone that will follow your prostate along as you get older, because all men will die with prostate cancer if they get old enough, but they will not die from prostate cancer. So the main thing is you need to get those that is going to be dangerous. So I'm not 100% sure about the numbers, but it's quite a high degree of men at about 80 that will have prostate CA.
Yeah, so if you look at autopsies of men that died from other causes, so about 30% of men in their 50s will have prostate cancer, and about 70% of men in their 70s will have prostate cancer. But they've died from other causes. This is not from prostate cancer deaths. So we all will develop prostate cancer, but not all of us will die from it, as you said. Mm-hmm. And that's where the false positive, so-called false positive, comes into play, is that you might then pick up a low-grade prostate cancer that would never cause any problems in your life, and all doctors will go ahead and treat that.
Yeah.
That's just, you've seen it now you need to do something about it. And it might be unnecessary treatment. It's a difficult one, but a recent study showed that if you combine it with a MRI and you do targeted biopsies, then you bring down the false or the unnecessary biopsies rate. So going forward, that might be the way to go, to combine all these things and use an MRI to guide you as well, and just don't just do prostate biopsies on blood failures and things like that. So I think you mentioned it, layer things.
So for me, the next layer will be ultrasound. It's a very, very, it's not very sensitive. So if you have all the money in the world, you'll just get an MRI and have a proper look at the prostate and a specific prostate scan, so that the layers are small enough that they can pick it up early. But obviously, monetary constraints, you can't just do an MRI on every person every year for his prostate. So, but okay, let's stop there with the the screening. So we talked about if you diagnosed. So, I mean, the nice thing is the treatment has also gotten a lot better. So, I mean, the biggest problem with prostate cancer was an open prostatectomy.
Yeah.
And now they can do it with the robots, so they can actually, smaller hands get in better, because one of the big what's the word I'm looking for, side effects of open prostatectomy was hurting the pudendal nerve.
Yeah.
And that means you don't have erection for the rest of your life, which was not cool.
I think from a practical side, we still do the PSA as a screening test in the practice, but if it's someone with a high risk, then they just go straight to the urologist and see if we can get an MRI done for them at the urologist.
Yeah. Agree.
Prostate, yes. So,
I think the next one will be colon again. I've, like I say, I've been touched, and bringing that into our next into what we're talking about, colon cancer. Me working in my day job, that's probably the cancer that I see that I do not want. It's a nasty cancer if it gets away. I don't think people screen enough. And even if you do screening only picks up about 30% of cancers. But if you do pick it up, it's like pretty much 100% that you'll get fixed, because like with my dad, very early, get the polyp under stage 3, you're good.
But the nice thing with the colonoscopy, you go in, you look for the cancer. If you see it, you can biopsy it, or you can, if it's a polyp, take it out completely. So it's an all-in-one procedure, and the data on it. If you do adequate screening, you reduce the risk of colon CA with 60% which is massive. Being under the top 4 cancers in South Africa for both boys and girls, it should be a no-brainer. We should screen more for colon cancers. But, if you speak to your buddies at the braai, the subject, we're in that age group now, so that subject arises and it's like, have you gone for your colonoscopy? And then the usual reaction is, we need to get over that. And we need to move on, and we need to get our colonoscopies. So entry used to be 50 years of age. We're thinking earlier, much earlier now, or 10 years before your family member that was diagnosed with cancer. So if your dad was diagnosed at 40, then you would start at 30, getting your colonoscopy. You can do the stool tests as well instead of the colonoscopy. I think the colonoscopy is standard of care at this point in time. That's the best one at the moment. You can do the stool test where they test for blood in the stools, and if it's positive, then you still need a colonoscopy. But you can do it. Where with the colonoscopy, you can do it if you've got a normal risk, you can do, and you've got a normal one, you can repeat it in 10 years according to the guidelines. Now, if you've got a slight increased risk, you'll do it 5 yearly. But with the stool test, you need to do it much almost yearly for the normal fit test. And if you've got the DNA one that I haven't seen around here, I've tried to get hold of those, but those you can do every 3 years.
Yeah, and I must say, it's such a non-event for me, like colonoscopy. I mean, my dad had his at 54, so I had my first colonoscopy when I was 42, and I'm going for my next one next month. And literally, it is such a non-event. And for me, knowing that if I don't have cancer, or the problem is if you do have cancer and it can't be cut out, then you'll have a bag on your tummy for the rest of your life. I mean, that's one of those things that I never ever want to have. So it is. I mean, if I have to pick one thing, everyone should do is a colonoscopy.
But I mean, the morbidity of that in your lifestyle. I mean, we like the outdoors, we like to do stuff, and if you go like through an event like that changes your whole life completely. Whereas if you've gone for your colonoscopy, they've picked it up early, you can carry on cycling, you can carry on going outdoors and enjoy life.
And I just want to bring, if we use the medical terms, I just want to bring it back. So the morbidity. So we talked about mortality of these things. If it's past stage 4, then the mortality, or if it will kill you, it's pretty much a dead certain that it will kill you in 5 years' time. The mortality, so the morbidity is how bad will it make your life? I mean, will it constrain your life and things that you do? And
that's directly connected to the stage that you pick it up. If you pick it up at stage 1 versus a stage 2, 3, or later on, that's a big impact on your life.
Yeah, because I mean, you don't really need your colon. I mean, it's nice to have, but if they pick something up, let them cut it out. And I mean, that's that. It's just get it diagnosed for me. Yeah. So I think for colon, the treatment is, if you find it, cut it out. If you don't find it and it's late, then obviously if it's spread, then the chemos and the targeted radiotherapy, all that comes in. But maybe we'll, once we've gone through our big things in the podcast, we'll get an oncologist in and talk about what to do in certain situations.
Good idea. Then the girls, shall we take with breast cancer, which is the big one for the girls. So breast cancer, 1 in 27 lifetime risk developing breast cancer in South Africa, which is quite common cancer. But screening for breast cancer, screening females between the ages of 40 and 69, brings down the mortality of breast cancer by 15 to 20%. So that's a big number. So another thing, we should screen. And I think that's the one that's probably done often.
Yeah. So again, if we talk about screening, so then we got to just differentiate about what the radiologists will do. Most people talk about a mammogram. So that's for the solids more. And then if there's masses that's not that solid, then the ultrasound scan.
Yeah. So the mammogram the sensitivity is quite high. It's almost 90% sensitivity for picking up a cancer in the breast tissue. More sensitive females above the age of 50, and less sensitive for females with dense breast tissue. It's still the gold standard, and it's a low dose X-ray. It's like 0.7 millisieverts, that exposure. So it's 3 months background radiation that you get from getting a mammogram done. Those ladies that has got thick or dense breast tissue, the sensitivity can come down to around about 50% or so. And often then we'll use a sonar to have a look at it and see if they can.
Okay, so I've had it wrong. The other way around.
See if they can see a mass in the dense tissue that they couldn't have picked up through the scanning with the mammogram. And then obviously the Rolls Royce is also an MRI in that scenario where you want to do that. I think for the girls at high risk, they will probably push for an MRI quicker. But yet again, layered. Do the mammogram, add on the sonar if the tissue was, if you had dense breast tissue, and if you're not sure, then you're going to step in with an MRI if you're concerned about the risk there.
Yeah, I want to put the base layer right at the onion peel. I want to say, mum, aunt, grandmother. So the risk lies there for me. Like go look first for close family, because those are the ones that'll kill you quick.
Yeah, absolutely. And that's why we've got this, form that people need to fill in when they sign up for the Innersight, with all these family questions of your mother and your brothers and your aunts and your uncles and everything. And people might think, why should I fill in all these forms? This is silly. But you need to spend time with it. And if you don't know the answer, actually phone someone and say, listen, aunt so-and-so, what did she die of? What age? And things. All the information that you can get from that is so important. If you can see that, we call it a disease tree, to figure out the risk for people for developing certain diseases, or in this case, cancers. So family history in breast cancer is so important. Other things as well. When did the menarche start? When was the first child born? Things like that as well. To look at the risk.
Yeah, and that just comes back to what we're saying. There's no one test, but putting all the layers together and adding, you're making you're making your sensitivity of your tests more and more as you add on. So, and
the same with the mammogram is, the more mammograms you've had, you can follow it up over time. You can then have digital images then of changes. So the sensitivity is better than if you one mammogram versus a follow-up mammogram. So just much better if you've had more images to compare with.
Yeah, that's the thing. I mean, we've talked about it when we started, but we feel somewhere between 35 and 40, you start hitting things. So pretty much indestructible till you're 35, unless you're very unlucky. But you need values and see how values change to make decisions. So, and I wish I knew earlier to start getting an ApoB value, like just at, let's say 25, 35, and where I am now, like, because when I picked it up, I was already too high, and I wish I never blew the top there. So, and I think it's the same with the cancers, like, and that's what we do at Innersight, is pick the big five, make sure that the big five don't hit you. I mean, the others you can put layers in, and I mean, when you talk to us, just ask, what else? What else can I do?
Exactly. Obviously, you can't screen for everything. It's impossible. But at least those that we know of, the big ones, let's at least put them aside and say, okay, we've done what we can. We've used what's available in this current point of time. And I think there's going to be a lot of excitement specifically in this field of detecting early cancers. We'll chat about it a little bit later. But yeah, we need to use these tests. As currently for the females, the South African guidelines state from 40 yearly mammograms, and then from about 55, you can either every second year or continue yearly. I don't think many females really goes yearly for their mammograms. Most of them will have one, and then 2 years later, realize that they haven't had this mammogram the previous year. So, but that's the guidelines. And the more you do, the more sensitive the test becomes.
Yeah. And I think for that same reason, I think we'll probably have to spend a whole podcast on how breast cancer treatment and how to go further with that. So maybe we'll get either oncologist or breast surgeon in to speak about the numbers and the treatment options. But I think we should maybe stay with girls and talk about cervical CA, which is still in South Africa more than the rest of the world. It's something we should screen for, and most girls have heard about the Pap smear. So
our prevalence is double that of the rest of the world, unfortunately. It's mainly because of a high HIV prevalence and HPV strain 16 and 18 that we have. So, yes, it's in South Africa, that's the number one killer for females in cancer. It's not the most common diagnosed cancer, but that's the one that actually causes the mortality. And it's so unnecessary. If you pick up cervical cancer early, it's curable. And hopefully now with the vaccine that comes in, then hopefully we can, over time, eradicate cervical cancer.
Yeah, and maybe that's the one we should screen earlier. We talk about 40. Most people, if they get to 40 and they have their first Pap smear, that's much too late.
Yeah, no. So the guidelines, South African guidelines, is at age 25. Start at age 25, and if you're HIV positive from the time of diagnosis, if that's before 25, then it's before 25. So we can do the Pap smear where they do the cytology smear, or they can do the HPV testing. So the HPV testing is a bit more sensitive, and you can have a bigger. With the HPV, you can do it every 5 years for a normal risk person versus the Pap smear every 3 years for a normal risk person.
Yeah. So just to bring it back again, so here genetics doesn't play such a bigger role, almost nothing really. Here it's the virus. The HPV that we're talking about is the human papilloma virus, and the substrains that we talked about earlier is number 16 and number 18. Yes. So there's a big list of substrains. A little bit of a problem with our vaccine coming from the UK, so not all the substrains are covered, but it is still quite a big, or it will give protection. So, and if you vaccinate against the virus, very much like chickenpox, then you protect yourself against not getting the virus, because the virus gives you the lesion, and the lesion becomes the cancer.
Absolutely. Yeah. So it's driven by, most of the cervical cancers in South Africa is driven by the virus. And that's why if we can vaccinate and get rid of the virus, then we lower the incidence of the cervical cancers.
So, but it comes back to screening, because if you screen, again, you can pick up most and you can cure most. So it's our killer because we don't screen enough.
Yes, absolutely.
Okay, while we're talking about screening, let's maybe move to nice things out there that might make our lives much easier about screening coming in the next 5 years, hopefully.
Yeah, so I think that's a big excitement in the cancer world. It's not so much the treatments that's coming out. There's one or two treatments that's causing some excitement, but the big thing is the early detection. So the blood testing, the detecting the DNA, it's so-called liquid biopsies that's coming out. It's still early days, but I'll refer to one test, the Gallery test, but there's many companies now falling in line, developing similar tests. And I think over the next 5 to 10 years, that's what we will be able to test for will be much, much better than what we're testing for now. So to take us back, we said 70% of cancers diagnosed, we don't have a screening test for. And we have basically around about 5 screening tests for cancers, more or less, give and take. Now, the liquid biopsy, they claim they can test for 50 cancers, which is amazing. I mean, 50 cancers versus 5, it's absolutely amazing. So what they do, it's a normal blood test, and then they look for DNA from cancers, in the blood, and they pick it up because the cancers shred the DNA into the blood. And then, so cancers that don't shred DNA, like brain tumors and things like that, you won't pick up through the test. And not all cancers shred the DNA in a similar way. So some are still more difficult to detect than others. But
yeah, I think maybe we should have maybe touched on it when we started off, but cancer is actually one of the cells that goes a little bit rogue, and it grows in a different way than the normal cell would, and it just replicates itself, and the body can't detect that it's the wrong one, because we form these rogue cells all the time, but the body's immune system picks them up and kills them. And somehow these rogue cells get have the way to hide that they're rogue, and then the body don't pick them up. And if they start growing, they make these growths, and they are cancers.
Yes, absolutely. Yeah. So we all have these cells that, as you say, get picked up through our immune system. And as they grow, some of them die. They shred some DNA in the growth process. You can pick up that signature of the cancer in the bloodstream, and so they can test for it. The problem at the moment with the test, well, let's start there. So there's a big study going on in the UK, in the National Health, where I think something like 140,000 people's enrolled in the study, specifically using this test. And at the end of this year, actually, they'll look at the results, and if they're happy, then they're going to enroll another 1 million people for 2024 and 2025 in the study, and then follow them up. So probably in the next 5 years or so, we'll have a lot more data to support this. At the moment, if you go look at the sensitivity of the test as published through this company, which is commercially available through a physician overseas, but not in South Africa, they state that the sensitivity, and we said that's the ability of the test to pick up a cancer. So for stage 1 cancers, it's still low. The average one is about 16%. 16%. For stage 2, it's about double, it's like 40%, and the stage 3 is about 70%. Okay, but we want that 16% actually be a little bit high, because that's the early ones that we want to detect.
The problem is it's not reached the lymph or the blood system at that point.
But at least, and then there's a difference between different types of cancer, because you'll see renal cell cancers is a lower sensitivity than lung cancer, and just due to the way that the specific tumor behaves. But we also need to think about the emotional bit about it, because if you do this test now, liquid biopsy, and you pick up a stage 1 tumor in this biopsy, it might be too small to see. So now you're in the scenario where you need to tell them, listen, Rudy, we've picked up this cancer somewhere. Fortunately, the test, the DNA signature can also point towards the type of cancer. So that helps a little bit. But what do you do now? Now you need to observe, because it's maybe still too small to see on a scan. And then we'll ask you, but we'll repeat the scan next year. But now there's something small somewhere in the body. So there's a big emotional thing. And I think we need to spend some time in educating ourselves. How are we going to manage that with the patients when they come to you? I don't think it's for every patient. Some people won't be able to cope with that information. Mm-hmm. Some people won't be able to deal with the fact that there's something, but we're not going to do anything now, and we need to wait until we see it. And once we see it, it will still be small enough that we can actually probably cure it then.
Yeah,
but
they'll have to train
emotional bit
people
going
specifically for that. I mean, just take myself, when they said there's something on your tummy, do you want to leave it? It looks a little bit angry. I said, cut it out now. Like, and it was cancer. So if they told me there's a lung cancer somewhere, like we'll check in a year's time, I'll be like, I'll pay for it myself, but go quicker to have the test.
Exactly. I think the big thing, hopefully, that's going to happen is that they'll be able to, from that signature, the DNA signature from the tumor, see which chemotherapies might be working for that specific
and maybe
signature, and then target it. And then you follow up, do a follow-up blood test, and if it's clean, then you've cured it. So that will probably I don't know. I mean, I'm guessing now, but in my head, that's the way that it should.
The immunotherapy focused at that.
You do the test, you pick up the DNA signature, and then you've got a treatment that might work for that DNA signature. You do the treatment and see if it's clear or not. Maybe that's sort of the future for cancer treatment. I don't know. But 50 possible cancers versus about 5 or so that we can screen for, that's a massive change. So we just need to figure out how we're going to fit it into the practice.
Because it's still quite expensive, eh? It's about 10,000 rand at the moment.
20,000 rand if you convert it, and not available here in South Africa at the moment. But I mean, it's commercially available overseas through a physician, and it's about $1,000. It's the last time I looked. So it's a lot of money. But the false positive rate that they've published is very low. So basically, if they pick it up, there's something somewhere. It's unlikely that it's false positive. We'll just need to find where it is. And is it big enough we can cut it out? It's just that period where it might not be big enough that you can cut it out to treat it. That might be an emotional burden for that time period.
Okay, but I think let's put it all together. So if you had to tell your brother what he should do, so that, I mean, we want to screen early and check for the big 5, layer the screening. Some tests need to be done every year. Not everything needs to be done every year. Most tests in either 5 years or 10 years. But the overlaying cancers that both boys and girls have got, skin, colon. For me, that's 2 that you have to screen, both boys and girls. And then
easy screenable, good results.
Yeah. And then for boys, prostate, start early, build a repertoire, get your velocity, know where you're headed.
And family history, important. If there's a family history, then you just uptick that straight down to the more like an MRI and stuff with the specialist.
And very much the same thing with girls.
Yeah.
Family history, that BRCA gene, if you've got that, you need to know, and then screen early and get data.
The game plan is, if it's there, try and pick it up early so we can do something about it until we've got better tools.
Great.
Yeah, awesome.
The 5th podcast, I love it. I think we got a lot of information out there for the guys and girls, and looking forward to the next one.
Yes.